Hi, my name is Colleen Steppa. I am a licensed clinical social worker and I work as a therapist in private practice. So this video today is just me describing what my process is for intake. Um, this can be generalizable to other therapists, but I'm just really speaking about what I do. So here is what to expect when you start therapy. So first thing, when I have a new client, usually they're contacting me via email or by phone or by one of the websites that I have a listing on, like Psychology Today or Therapy Den. Within that communication, people usually ask me questions about like what they might pay for therapy, what their insurance covers, what kinds of things I work with people on, what are my openings, what time slots I have. So usually I'm going to go ahead and answer whatever those questions are, and then we're going to get to the same information that everybody gets at some point. So I typically will send people an email that has some general info about my practice, which is like the hours that I accept clients, when I have openings, what types of issues I tend to work on, what insurances I accept, and like other things that I allow people to do or not do. Like for me, I let my clients choose if they want to see me weekly, bi-weekly, or monthly. And then we talk about when they want to schedule those appointments. Some other therapists might have different regulations. And they also might have things stipulated based on like, if you're court order, then you're going to have to go with a certain schedule rather than just when you choose to go, right? Another caveat with that is if a therapist accepts something called an EAP, an employee assistance program, typically those are going to dictate how many sessions that you're allowed to have. I think it's usually like 10 a year, depending on the program. So then that might limit when you're able to schedule or how you're able to schedule those. So those questions we usually go through in the first email or so or phone call. A lot of times people like to tell me a little bit about themselves and what they're going through, and they ask if that's something that I can work with them on, and I would either answer yes or no, depending on the thing. So from there, I send consent forms online because I think it's more convenient. And I also have a mostly online-based practice, which means most of my clients are seeing me kind of like this video, like we're doing a video type chat. It is a video chat. It's not a video type chat. It's a video chat. So we use a secure system called Simple Practice. I send forms through that, and then I have people sign those forms electronically. So typical forms that you'll see if you are starting therapy would be what they call consents, like an informed consent. So that's a document that has the therapy policies and procedures in it. So I have like my late policy, like if you're going to cancel. I talk about like what are boundaries within therapy, how do I protect your confidentiality. I have another release that's about HIPAA, like how I store your information. I have another release for telehealth, just saying that you consent to do a video chat as the form of therapy. I have another one for COVID. If you come into the office, basically saying that I'm not liable if you get COVID. Even though we do require masks for COVID purposes. I have another one that's a technology one in case like an email gets hacked or something. So I don't know if every therapist has all of those, but those are just some examples. You probably will have one that's like a consent to pay, saying that you need to pay for your sessions in a certain time frame, or that you can be discharged from therapy, saying how often you need to like tell the therapist that you want to schedule an appointment or your discharge. For example, like if I have a client who doesn't talk to me for 6 months, they're probably not going to be on my caseload anymore because I don't think they want therapy anymore. So there's usually rules and policies lined out in those documents for your therapist. So you can, on my system, you can click through those and you can keep copies to reference, which is really nice for people to have. Another thing I think is usually required for most professions, it's definitely required for social workers. My documents have my license number on them. So if you need to report me to the state licensing board, there you go. You got it. I think there's also some information about like what degrees I hold. So you can, if you want to like do some kind of background checking thing, like Google me and make sure I'm legit. Any licensed practitioner, you should be able to look up their license. Like they should have either their like first and last name or birth date or their license number. You should be able to take some of that data and find it on their state licensing board's website. I know you can do that on the Board of Social Work's website. So after people fill out the consent forms, we would usually have a date picked to do our intake session. I do intakes that are like about the same length as a regular session, just so we can schedule them more easily. And then typical things we're going to talk about in an intake session would be we're going to go over some assessments. Oh, I forgot to say that. Another thing that's with the paperwork, I have like 3 or 4 assessments. So those are measuring your symptoms, like your anxiety or depressive symptoms. And then I have another one that measures dissociation, just so we can see where you're at if we want to do something like EMDR, which is a therapy modality where we work with trauma reprocessing. So I kind of just want to have a baseline of where those scores are at. It's not bad or good to have a certain score. It's just giving us kind of like a starting point to figure out where we need to go from there. So when I meet somebody for the first time, we go over like what I saw in their intake paperwork, what was the demographic information they gave me about like why they wanted to seek out therapy, who's in their family, what's going on with relationships, what are their symptoms, how bad are their symptoms, and then anything else that's kind of concerning to them at that point. We'd also go over a little bit of health history, like what medications they're taking, family health that's relevant to them, family mental health, if they know it, and any kind of substance abuse history for them or the family. So all of that is just giving me kind of a picture of like what's going on with this person psychologically. So we call it a biopsychosocial assessment. It's just taking all different areas of that person's life, understanding where they're at, so we have a direction to go with therapy. Right? So that's the first session. We're doing that. I also do something called a mental status exam in my first session, which is a set of questions that's kind of like if you've ever been to the hospital, if you hit your head or had a concussion, and you had a nurse ask questions like, what year is it? Or like, what season is it? Who's the president? Right? So the questions are similar to that. They're not those questions, but it's just evaluating where someone's at and if they're able to orient to time and space. Most of the time, the people that are contacting me and that I'm working with are, there's no concerns that I have about them having any kind of like serious neurological issue that would mean that they're not oriented to time and space in that way. But in some fields of social work or therapy, that is more apparent or prevalent. So those kinds of scores are important. That's for me just kind of like a real brief screening tool to see if somebody needs to be referred to a doctor or a neurologist for something more serious. So that's pretty much what the first session is. I let people ask questions. We get a pretty detailed view of their biopsychosocial life. So that's their biological things going on, psychological, and then social environment. So first session, then we schedule the second one. I let people decide how often we want to meet. We discuss that usually in the first session based on how severe their symptoms are, what their schedule is like, what they can afford, and things like that. So the second session, we're going to do what's called a treatment plan. A treatment plan is basically just goals. So goals that are therapy related. And I usually have like 1 to 3 goals because I think that's what's manageable for people. And I want them to be goals that are just a little bit of a stretch. Sometimes people are really ambitious and they want the goals to be more of a stretch, but I want at least one goal that we're pretty sure that we'll be able to achieve within like 3 to 4 months so that people can have some measurable success and don't feel like therapy is a failure all the time, which is it's good to have goals that you can actually see you're moving towards and having progress in. So the way we make goals is like traditional SMART goals. So that's specific, measurable, attainable, realistic, and time oriented. So I'm going to have dates of like when we're going to check the goals. We're going to look at them again. I would have something on there that's specific enough that we can actually see if they've achieved it or not, and then have something that's realistic. So a lot of times people come to that session and they're like, I don't know how to make these kind of goals. I'm just going to give an example of one that's pretty common. So I might use their assessment scores as a measuring yardstick for if some kinds of symptoms are getting better or worse. So if they have an assessment for anxiety symptoms, I might use that as a yardstick for is this person experiencing less anxiety overall in their life as a result of 3 months of therapy. So we would re-administer the anxiety assessment, which it's really just them checking through boxes of if this statement is true most of the time, all of the time, something like that, with different anxiety symptoms. So we go through that. That can be one assessment tool that we use to figure out if their symptoms are getting better. But we could also use something like um, the amount of times that they use a coping skill. This is a really good one that I like to use as a goal. So maybe somebody comes into therapy and they have a really hard time with anxiety attacks, and so we want to just introduce a new coping skill that they're going to use when they have an anxiety attack. We're not going to make the goal that the anxiety attacks go away completely, because that might not be reasonable and that's not necessarily under their control. Because if they wanted it to happen and they had the power for it to just go away, they probably wouldn't be seeing me in the first place. So we might have a goal that's something like, you will use X coping skill 2 times a week for the next few months. So the idea is sometimes is that you use the coping skill before you need it, so you're used to using it, and then when you have an anxiety attack, hopefully you remember and you're able to apply it in that moment. So that's basically what the therapy goals are like for the treatment plan. They sign that document, and then we review those periodically. So depending on somebody's insurance, we might review them more frequently. If they want to amend them or put different goals on there, we can always revise those. But I think the minimum that you can look at the goals is like once a year for the Board of Social Work. I like to do it more often than that, mostly because people feel good about themselves when they see that they've achieved goals, and most of the time they are. If we're doing good goals, they're getting achieved. So that's basically what happens in the first 2 sessions of therapy with me. I hope that was informative and helpful and shine a little bit of light on what the therapy process is. All right, thanks. Have a good day.